Today, meeting the cancer prevention and care needs of North Carolina's indigenous communities with Ronny Bell, PhD, MS, and Marc Emerson, PhD, MPH. Thank you both so much for being here today. And let's provide an introduction for you, Dr. Bell. Ronny Bell, PhD, MS, is a professor in the Department of Social Sciences and Health Policy at the Division of Public Health Sciences at the Wake Forest School of Medicine and Associate Director of the Community Outreach and Engagement and Director of the Office of Cancer Health Equity at Wake Forest Baptist Comprehensive Cancer Center. From 2016 to 2020, he served as professor and chair at the Department of Public Health and associate director of the Center of Health Disparities in the Brody School of Medicine at East Carolina University. He's a lifelong resident of North Carolina. He grew up in Robeson County, North Carolina, and is an enrolled member of the Lumbee tribe. He received his undergraduate degree in public health nutrition from the University of North Carolina at Chapel Hill and his master's and PhD in foods and nutrition from the University of North Carolina, Greensboro. His research focused on chronic disease disparities with an emphasis on rural and underserved populations. Dr. Bell, welcome. And what's maybe one thing we should know outside of your professional bio?
I became a grandfather this past year, so I'm really excited about that. So I have a 13-month-old grandson named Everett, and we get to keep him every day, and he is such a joy.
Oh my gosh, congratulations. That is great. Let's see, Dr. Emerson, PhD, MPH, interested in developing an integrated understanding of how lived experience, accessing care, mental health, and disease characteristics affect cancer outcomes. He is committed to meaningful research efforts focused on sustainable health equity that incorporates the history and context of subpopulations to address the unique challenges that lead to health disparities. Dr. Emerson, welcome. And I'll pose the same question to you. What's one thing we should know outside of your professional bio?
So I think so I like to run. So I try to run, I guess, pandemic aside, some marathons every year. And so the double fun fact of all of this is I have run a barefoot marathon before, or I've run a marathon barefoot, but only because I forgot my running shoes.
Wow, well, that's impressive. All right, well, thank you both so much for being here. I mentioned we're going to use poll everywhere. Here's the first question we'll be asking. Information and statistics about cancer with North Carolina's Indigenous Americans living in North Carolina is often misclassified. We try to make this first one pretty easy. I think you'll get that one, but true A, false B, and again, this is entirely anonymous. And I'll just say for our disclosures, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with interests as defined by the ACCME. Ronny Bell, PhD, MS, and Marc Emerson, PhD, MPH, have no financial relationships with commercial interests as defined by the ACCME. So let's look at that poll, and that should be open now so you can go ahead and respond to that. So if you think that information is often about, and statistics about cancer with North Carolina's Indigenous Americans living in North Carolina is often misclassified, we're trending pretty heavily in the true. Dr. Bell, Dr. Emerson, how are they doing?
Did well.
Great, great. Well, we'll go ahead and turn it over to you, Dr. Bell.
Dr. Emerson is actually first.
Oh, I'm sorry, Dr. Emerson, we'll turn it over to you first. Thank you.
Great. Thank you so much, Tim, for the introduction. Starting this, first, just want to acknowledge and recognize the land and sovereignty of Native Indigenous nations. So this area, Durham County, Orange County, Durham, Duke, North Carolina, Chapel Hill, are the traditional lands of the Occaneechi, the Eno, the Saponi, and the Tuolani people. And so these are unceded territories of which people have lived in generations of kinship systems that were violently displaced by the colonization of North Carolina. But we still have indigenous nations living here today with the Lumbee, Eastern Band, Cherokee, Saponi nations within the region and within the state. So I just wanted to start us off, I guess, on the foot of encouraging us to be mindful of whose land we're on and the territories that they're contesting from the state and the federal government, as well as many indigenous people who live in the area and work in these regions today. Next slide, please. Okay, so yeah, starting this off, the question is, what is it, or Tim, do you want to read this, or is this? Okay.
Sure.
Yeah.
What is a type of socioeconomic or health disparity that you may have heard about that one might associate with American Indians, Alaskan Natives? So this is open, any thing that you want to go ahead and submit here. Again, this is anonymous.
Yeah, it's anonymous, open-ended, and I wanted to start this just thinking about kind of setting the stage of this overall bigger context, right, of like thinking about a lot of issues that can be systemic and thinking about health disparity and thinking about relationship to chronic disease, accessing healthcare. And, I wish I could be all there with y'all in person today. So I think kind of thinking through some of these things, at least in a more interactive way, I think makes it a little more engaging.
Great. And I know we've got, I apologize, something seems to be a little bit off with Poll Everywhere today. I think it's wanting me to vet the responses, and unfortunately, it's not quite giving me access today, and I apologize for that.
No problem, Tim.
So I know several of you are responding, and it is not allowing those responses to promote. So if anyone wants to share in the chat, they may, and bear with me for just another minute, and I'll see if I can fix that. Let's see, it is. That should be promoting those right on through, and for some reason it is not. So I would say, Dr. Emerson, let's go ahead and move on to the next slide, and I'll see if I can fix that, and we can come back to that one.
Okay, no problem. That sounds good.
Oh,
Thanks,
and
Tim.
I do see some in the chat that have already come in. Thank you all for being so adaptable. Language barrier, poverty, oppression, cancer, food deserts, diabetes, alcoholism.
Awesome. Yeah, thank you all for engaging me on this. Yeah, it's an interesting question, I think. Yeah, but moving on, so I also want to start by acknowledging the traditional Navajo protocol. So that's my background, is Navajo. So part of the Navajo protocol is for me to introduce myself in my language. And so before I do, I just want to give a little context in that this is a practice that is rooted in relationality and kinship. And so it helps identify where I come from. And I think more so, it helps establish relationality with one another. So Aat Adherence, Marc Emerson Nishne, Auto Ma Adeshkijin Nishne, Senam Bithni Bashachin, Ma Adeshkijin Desha Nully, Totally Desha Che. So basically I started the introduction with my mom's clan, which I say I am, and then I say I'm born for of service to in my father's clan. And we start with the maternal side because we're matrilineal peoples. And then we introduce ourselves through our grandmother's kinship network and then our grandfather's. Next slide, please. And so overall, yeah, I'm just really honored to be here today, and I just really appreciate the opportunity. And I just want to say I really see myself, my role this morning or this afternoon is really setting the stage for Ronny, who I'm just really excited to hear from. I think Ronny just does incredible work. And so I'm really just viewing myself as the hype man today for Ronny. And I just kind of want to set the stage, and Ronny's going to go over a lot of good information, I think, more locally, and kind of zooming in on North Carolina specific Indigenous needs, which he's and so for me, setting that stage is really kind of zooming out and thinking about more some national stage kind of issues that I think we can kind of chew on as we kind of move into the more meat of the lecture with Ronny. Next slide, please.
Great. And Dr. Emerson, I was able to, they changed things up on us a little bit. I'm going to see if I can show that response. Oh, boy. There we go. So No, still not working. Oh, it's going to bring them in very slowly.
Oh, cool. Okay.
So
All right.
we can take a few seconds at least to see some of the other responses to that first poll.
Yeah, and as these pop up, I think these are really good responses. Again, I appreciate your all interaction, especially during COVID when we're all kind of separated by these screens. And, and so I appreciate kind of this interaction, because I think if we were in person, I think these things that are coming up will help kind of facilitate. And so keeping these things in mind, I think as we go through the next hour and these in what we're presenting, I think is a good kind of like context to kind of hold a lot of these issues that we might be talking about today. Yeah, these are great.
All right, I'll go ahead and move that up to that next slide. There you go.
Awesome. All right, thank you, Tim. Yeah, so part of that zooming out, thinking about kind of this national stage, and when we look at national level AA and data, there's just a few things I want to mention to keep in mind. One is that it's important to recognize the great diversity, I think, with AIN. And so even American Indian, Alaska Native kind of grouped together often can mask a lot of information, right? And so this is a non-monolithic group. So there's currently over 570 federally recognized tribes. And so each of these tribes have their own culture, norms, language, customs, and geographical location, as you can see here kind of depicted on the graphic here on the right. It's also important to note the unique association with healthcare, I think. So for the Navajo, my tribe, for example, is treaty-based in how we access healthcare and the services and delivery of healthcare. And so across the board, though, in order to receive care, you need to be a member of a federally recognized tribe and then also live near tribal lands. And so as you can imagine, not being near an IHS, an Indian Health Service facility, can create these additional barriers, including greater travel distance to receive care. And so this map here is kind of depicting that. So in the dark blue are U.S. counties that are adjacent to tribal lands and territories. And I guess we can also get kind of a flavor for the regional diversity as well, which I think, again, is important when thinking about different environmental exposures that can differ across the U.S. and Alaska in terms of how that's relevant to chronic disease. Next slide, please. And so then another major watershed issue that I want you to kind of bear in mind at the national level for AAN populations is this urban native versus res native divide. And so currently there's over 70% of AIN have moved off of their tribal lands and are in more urban environments. So using myself as an example, I moved away from the Navajo Nation, for upward mobility reasons. I moved here for UNC, for school, and for a job, et cetera. So anecdotally, I think that's kind of what is helping drive this proportion. But also important to keep in mind, too, including myself as an example, I still return home often to visit relatives, attend family gatherings, celebrations, attend and participate in our own cultural and community activities. And so next slide, please. So previously, with some colleagues in California, Kaiser Permanente, we've done some work looking into this group, a particular subgroup of the urban experience for natives in terms of their cancer access, in terms of their cancer experience and treatments. And so kind of to just quickly set the stage, we had done some work previously looking at just overall disparities and survival, and then also this kind of tie-in with comorbidities and pre-existing conditions that can be unique in this Native community as well. Next slide. And so to quickly just highlight some of our findings that are relevant, kind of thinking about setting the stage for this next question that we asked, we did find substantially higher all-cause mortality among breast cancer, for natives and this also persisted when we adjusted for important patient and disease characteristics and comorbidities as well. Next slide. And I just mentioned that kind of set the stage because I think our next question as collaborators was thinking about what this treatment and access kind of issue looked like and trying to fill in that knowledge gap as well. And so here what we were looking at was initiation and adherence to adjuvant endocrine therapy among this insured urban AIN population. And so to give you a quick background on why I think it's important to look at this breast cancer treatment for this particular population of insured AIN women, here what we're looking at, we can see the recent U.S. breast cancer mortality rate is declining for most women of other race ethnicities, but this isn't particularly true for Native women. And then within HR positive breast cancers, the 5-year survival rate, specific survival rate remains lower for AIN women compared to non-Hispanic white women. So overall, this implicates factors beyond tumor biology, including treatment differences. And so previous research has shown this difference in disparity for AAT initiation and adherence by race ethnicity, but this particular relationship for Native women remains poorly understood. And so one of the reasons that this could be is that the IHS, the Indian Health Service Contract Health Service Delivery, from which most of the information we have for cancer for AIN people comes from, lack this type of treatment data. And then again, notably, that's over 70% of urbans live in, of natives live in urban areas and may access their specialty care, which cancer care is a part of outside of these Indian Health Service units. Next slide. So bearing all that in mind, our objective here was to evaluate whether AAT initiation adherence were particularly lower for AIN women than other race ethnicities. Next slide. And so to look at this, we use the source population of Kaiser Permanente of Northern California, which I'm sure many are aware of, is a large integrative healthcare system in Northern California. And so using this data provided us a few, I think, strengths here. One was this rich quality AAT information, given access to AAT prescribing dispensing data. So we had information on data prescription, refill dates, number of pills dispensed, and then also the ability to track AAT use over time within this stable population of the Bay Area. Next slide. And so of the patients enrolled in Kaiser Permanente Northern California healthcare system, our analytic sample was 23,680 AT eligible patients from the time period of 1997 to 2014. And so here, kind of the overall overview here was race ethnicity was our main exposure, and our outcomes were initiation and adherence to AAT. Next slide, please. And so AAT initiation was defined as having at least one filled prescription within 12 months of diagnosis, as you can see in this boxed in area of the schematic here. Next slide. And then our AAT adherence was defined as a proportion of days covered within each of these 12-month time periods. And we categorize women as being adherent if their proportion of days covered met or exceeded 80%. And so we calculated the AT adherence for each of these 5 12-month time bands here following the first prescription fill. Next slide. So yeah, overall, what did we find? We found that 83% women were AAT initiators, and by the end of the 5-year time period, overall, that close to 60% were AAT adherent. But then when we break this down by race ethnicity, as you can see here, AAT women had the second lowest AAT initiation. Next slide. And the next result we're looking at here is AAT adherence by race over the 5-year study period following AAT initiation by race ethnicity. Next slide, I think. Yeah, and so we're looking at the same graphic here, but we're just zooming in on the colors here of looking at AIN women and non-Hispanic white women. And we can see here that for the Native women compared to all other race ethnicities, that Native women have the lowest AAT adherence by the end of the 5-year period at 51%. Next slide. So yeah, I think, kind of zooming out, I think one of the main takeaways here is thinking about this AAT treatment gap, right? So we found at the end of the 5-year study period, the total underutilization, which is thinking about the women who didn't start and then also who didn't adhere through the 5-year period among those who were eligible, was greatest among the Native women at 71% compared to other race ethnicities. Next slide. And so I think, more meta, like zooming out, the takeaway here is that AAT initiation adherence are particularly low for this population of insured Native women. And I think it's important to point out that this kind of is a best case scenario for access, right? So our study focused on insured Native women, and so therefore represented kind of this better selection for a greater likelihood to adhere to treatment. So it's also important to acknowledge that this group most likely had lower barriers compared to other Native women who may lack health insurance, which again is the majority of Native persons, or who also live in rural locations or who live on tribal lands. So that's what I mean in terms of this best case scenario for access, yet we still see these substantial racial disparities. And so I think kind of the next thing is thinking about designing these interventions specifically in addressing these cancer disparities in research to reduce these treatment disparities, particularly for this population, need to be kept in mind. Next slide. Yeah, so I'm sure you're all familiar with this map. This is North Carolina, and if you didn't know North Carolina, there's the total square miles in terms of land area, which is nearly 54,000. In the next slide. And then this is just a superimposed land area comparison for the Navajo Nation over the state of North Carolina. So you can see it's about, half the size in terms of land area. So I just want you to keep this in mind. Next slide. Because here that on the left side, you can see in the grayed in area, that's the Navajo Nation. And so keeping in mind that land size, so the Navajo Nation only has 13 grocery stores. And they only have 8, which are depicted in the dots there. And then in the stars are the Indian Health Service delivery units. And so these don't have specialty care as well. And so, within these 8 clinic areas, just thinking about that large land area, and going back to kind of this underlying context of what are these disparities, and how these can be created. These are examples in thinking about, someone had said in the beginning, food desert, right? And accessing food and healthy food and how that can relate to nutrition and well-being and mental health and all these systemic issues that I think can go in the whole cancer care continuum here. And then just as a personal example on the right side of the slide here. So my father had cancer, stomach cancer, diagnosed at a late stage. And so what I'm trying to depict here is Shiprock is where our farm is. And so kind of being the sole only child caretaker for my father, the red arrow goes all the way to Albuquerque, New Mexico, which is where he received his surgery and follow-up and consultation appointment. So, that's over 200 miles away. And so that's, just a personal example of what accessing care looks like. And then that 28 miles away was where he received his chemo treatments. And so you can tell those are kind of off, those are in border towns off the reservation. And I put the little pens there, being in community and hearing from other community members. These are other border towns where, a lot of community members receive their cancer care as well. Next slide. Yeah, and I just want to really quickly go over these things and, kind of zooming in a little bit to North Carolina. And so this wasn't specific within AIN populations, but I think this is kind of like thinking about the context of treatment initiation, treatment duration. Here's some work that we've been doing recently within the Carolina Breast Cancer Study. And so this is thinking past this time of just when does the importance of this timely care of when the time frame from when a woman is diagnosed to her first treatment, and thinking past that a little bit more into the treatment duration. And so this is some research that we've done recently looking at this treatment duration of whether that's timely or prolonged. Next slide. And we've also looked at this by treatment type. And so just really quickly, I think what I want you to take away from the Sansky flow diagram is that when we start on the left here with our total cohort, and then as we start shifting to the right, we can see how at different the stage of cancer and initiation and treatment duration, how these delays in care can start to compound. Next slide. And these are further compounded when we look at the right side here. What we're looking at is we're looking at these issues of having more barriers to accessing care, and then also this kind of intersection of low SES versus high SES. And we're looking at this by race. And so we can see that when we look into this period past just treatment initiation into how long the treatment takes, these further expose these compounding issues of within treatment duration. Next slide. And so those are some of the takeaways. And here we're looking at Black women in North Carolina and these kind of systemic issues, right? And how there's greater delays in accessing care. And so part of our research is looking at this treatment duration and kind of as a point of, or a touch point of care, and thinking about how important that time period can be as well in thinking about keeping that in mind. Next slide. Just want to make sure we have time for Ronny, sorry. And lastly, just want to highlight some work that we have in progress too. And so working with collaborators at Johns Hopkins in the Bloomberg School of Public Health and Center for American Indian Health, developing their collaboration that will lead to new data, I think, and looking at these barriers and facilitators to cancer screening. And just want to highlight this community strengths, because I think that's important as well. Listening to my community, I think often they're just tired of being framed in this deficit way as well, in thinking about how high rates of all these negative things or low rates of things that are positive. So really tying into what are these community strengths and connections to care in American Indian communities. And so ultimately hoping to inform interventions to reduce, in this case, screening disparities for screenable cancers for American Indians patients specifically living on tribal lands. I think that is my last slide. Is that right, Tim?
Yes, we just have one last question. In our study, we found what percentage of AIAN women adhered to AET after the 5-year period. We can tell that some folks got a jump on that, and we're, I think, paying very close attention. But let's
Awesome.
wait a few more seconds. I think this audience is really focused on this. Dr. Emerson, what was that you were looking for there in terms of the response?
Yeah, no, you all are spot on. This is great. Yeah, and yeah, so I think this is thinking about some of these kind of compounding issues and thinking about the specific subpopulation and you know, I think overall, right, like, and I'm sure Ronny will do a better job articulating this than I will. And in these gaps, there's a lot of gaps. There's a lot of knowledge to be filled in when looking at specific Indigenous communities and accessing care, and these kind of things that I try to highlight in terms of the disparity between urban populations and those living on tribal lands. I mean, there's a lot of work to be done there. And I think, you know, this kind of will highlight some of the areas that, well, we are doing a pretty good job in certain areas. It just, and we see a lot of these pretty stark disparities, you know, thinking about those other subpopulations that may be experiencing even greater barriers or trouble accessing care even greater, or tying in these other issues in terms of mental health or in terms of, family caretaking, like my personal example I brought up with my father, you know. So this is great. Thank you.
All right. Thank you so much. And Dr. Bell, there's your first slide all queued up.
Thank you, Tim, to your team for pulling this presentation together. And thank you to Dr. Emerson for a wonderful presentation. It's great to get to know you and to have you here in North Carolina and to hear about your personal journey and your research and your passion. So looking forward to continuing to work with you in the future. So one of the great things about North Carolina is our racial and ethnic diversity, and particularly the diversity of our American Indian population. We have 8 tribes here in North Carolina, and I want to pay tribute to them, to the indigenous peoples who live here in what we call North Carolina now, who have lived here for many centuries. And so the 8 tribes here in North Carolina, the Eastern Band of Cherokee Indians in the western part of the state, the Coharie, the Lumbee, my tribe, and the Waccamaw-Siouan in the southeastern part of the state, the Meherrin and Halawa-Saponi in the northeastern part of the state, and the Saponi and the Occaneechi in the north central part of the state. I also want to recognize that we have 4 urban Indian organizations in North Carolina, the Metrolina Native American Association in Charlotte, the Triangle Native American Society in Raleigh, the Guilford Native American Association in Greensboro, and the Cumberland County Association for Indian People in Fayetteville. So a lot of people don't know that North Carolina has one of the largest American Indian populations in the country and has the largest population in the eastern United States. We have about 160,000 people who identify as American Indian Alaska Native as of the most recent census, and that represents about 1.6% of the state's population. And I want to pay tribute to one of our elders here in North Carolina, Miss Sonora Lynch, who's in the bottom right photo there. She's a well-respected, national and internationally recognized artist for her tremendous work. And if you're on the UNC campus over near the Student Center, you can see some of her work there that is on display. With regard to cancer, the cancer burden of American Indians in North Carolina, there's a bit of a kind of a mixed message, if you will. We are fortunate here in North Carolina that we do have data that is specific to the American Indian population with some caveats. But it was not that long ago where we didn't have any data that, if you went to the State Center for Health Statistics, you might get data that was, white, non-white, or white, black, other. And so I'm very grateful to have the opportunity to be able to access the data that is available to us on different health issues that affect American Indian populations, and particularly cancer-related data. But as we'll sort of go through this presentation, you'll see that there are some challenges as it relates to understanding the full picture of the cancer burden. But if you go to the cancer burden document put together by the state Cancer Prevention and Control Branch, you'll see that the incidence rate for cancer for American Indians was 318.9 per 100,000 in 2010 to 2014, and the mortality rate around that same time was 156.5. And that represents a rate that is the incidence rate fairly close to what we see for the Hispanic population. The mortality rate, third among the 4 major racial and ethnic populations of the state, just behind that of the non-Hispanic white population. But if you break things down, particularly for specific types of cancer, you get a better picture. And I apologize that there's a lot of numbers here and some of the numbers are very small, but you can kind of get a better understanding of the true cancer burden for American Indians in our state. And so, again, we do have access to data which breaks things down for us by particular cancer types. Now, some of those cancer types for a relatively small population like the American Indian population doesn't really give us a true sense of, given that the numbers are small, it doesn't give us a true picture of how that particular cancer is impacting the population. But certainly for the major cancers, breast, colorectal, lung, prostate, we do have enough of those cases to give us some indication of how these conditions are disparate related to the non-Hispanic white population. And in particular, if we look at mortality rates, we see, again, a clearer picture of specific types of cancers which adversely affect the American Indian population, such as higher rates for death from colorectal cancer, higher rates for liver cancer, higher rates, fairly significantly higher rates of lung and bronchus cancers, slightly higher rates of deaths from breast cancer, higher rates from prostate cancer as well. So we do see that picture that there are some cancers that we do need to be concerned about for its impact in the American Indian population. Another piece of data that is relevant to this conversation is the data looking at diagnosis at a late stage for particular types of cancers. And so we do see that the American Indian population, for the most part, doesn't seem to have a disparate rates of late stage diagnosis compared to other populations. I mean, we see, slightly higher rates for lung cancer. And if you'll recall from the previous slide that there are significantly higher lung cancer death rates for American Indians. But by and large, this doesn't really tell us that there's a whole lot disparate with the relationship to diagnosis at a later stage for American Indian populations. But what we certainly know about the health of Native people in North Carolina is that we see some of these upstream factors that contribute to adverse health outcomes. And so looking at some of the social determinants of health, formal education, income, housing, poverty, all of those things generally are more disparate for American Indian populations compared to the non-Hispanic white population, which would indicate that there should be more downstream effects related to chronic diseases like cancer. One area where we know there's a specific disparity is the rates of use of harmful tobacco or use of tobacco in the form of cigarettes for the American Indian population in our state. If you look at the data from the 2018 Health Equity Report from the State Office of Minority Health and Health Disparities, you'll see that the rate reported there for adults indicating current smoking status was 26.2% compared to the state rate of 17.9%. And so, again, an area of concern, and that manifests itself in that higher rate of death from lung cancer for American Indians in our state. Now, I gave a little caveat at the beginning of my presentation to say that there is some concerns about the data that we have available to us. One is the small numbers for certain types of cancers. There's missing data in a lot of areas for cancer risk factors and cancer screening. But in particular, something that is a concern is the issue of racial misclassification for American Indians. And so there's a report that was published in 2008 by faculty at UNC Chapel Hill in collaboration with the State Center for Health Statistics to try to get a handle on this issue, to see if we were to take into consideration what occurs as it relates to racial misclassification, how that would impact the cancer incidence rates that we see in our population. And so this report showed that if you were to compare data from the tribal rolls for the 8 tribes, actually they looked at 7 of the 8 tribes since the Eastern Band of Cherokee report their data to the Indian Health Service. So looking at the cancer registry data and tribal roll data, they indicated that there was at least 18% misclassification, which could have a significant impact on the cancer incidence rates. And from their estimation, looking at the 4 major cancers, they said if you took this misclassification into consideration, the true rate of cancer incidence would be about 19% higher than it would be if you were not taking that into consideration. So that's something that we need to pay attention to, is that in some cases there are people who are receiving healthcare services in North Carolina who identify as American Indian, but who are not classified as such in the data classification systems. And there's a lot of efforts going on across the state to try to address some of the health issues, and particularly cancer issues in our state. There at UNC, you have a wonderful American Indian Center that's doing some great work. They have established what's called the Healthy Native North Carolinians program, where they partnered with 7 of the 8 tribes in the state to try to develop ground level efforts to try to promote healthy lifestyles, which would have an impact on cancer incidence and mortality. And so the tribes sort of worked in their communities to identify what would be the most effective approaches to promote physical activity and healthy eating. Some of the tribes created community gardens. Some of them, just like the Saponi tribe, just recently had their 5K and 1 mile fun run that they do every year as a part of the Healthy Native North Carolina's initiative. And so a lot of wonderful activities going on as a part of this effort. I had the opportunity to collaborate with Dr. Leah Fryerich and Dr. Dan Rulin at UNC Chapel Hill, partnering with them and the 3 of the tribes in Eastern North Carolina to develop what's called the HOPE project, which is a shared decision-making strategy to try to encourage American Indian people to get screened for colorectal cancer. And so basically it was an opportunity to educate people about colorectal cancer and about the options that are available to get screened. And so as a part of that initiative, we put together a video to walk people through the process of understanding what colorectal cancer is and the options for screening. And it was very well received. And actually, we had a paper published to look at some of the outcome measures. And so you can see that there were significant increases in knowledge, increases in positive attitudes toward colorectal cancer screenings, increases in perceived social norms, increases in self-efficacy, a very significant increase in intention to screen among people who were not meeting the guidelines for screening. And so we are hopeful that this will be a great effort to get more people involved in discussions with their healthcare providers about colorectal cancer screening, particularly now since the minimum age for screening has been reduced to 45. Also want to pay homage to my colleague, Dr. Lisa Leffler at Western Carolina University. She is the director of the Center for Native Health there at Western Carolina. And so they do a lot of efforts in partnership with the Eastern Band Cherokee to do education and training and culturally based culturally based initiatives working towards promoting healthy lifestyles in the Eastern Band population. And I have had the privilege of being the chair of the North Carolina American Indian Health Board for the last 10 years. Our mission is to focus on research, education, and advocacy for the American Indian tribes and families in our state. And so we do a lot of efforts to promote healthy living. This is Charlene Hunt, who's our program manager, and she's going out in the community as to the extent that we can now with COVID to try to help promote some of the efforts around healthy lifestyles. And we've done a number of things in this space. We created a series of infographics on American Indian health issues. And so this is the Cancer Disparities infographic. These are available on the State Center for Health Statistics and the Office of Minority Health website if you would like to download these. We also did a booklets on American Indian health for men and women, and we use kind of a storytelling motif to convey these health messages. And these are available on our the North Carolina American Indian Health Board website at ncaihb.org. We also we did a documentary where we interviewed Lumbee Indian prostate cancer survivors and talked to them about their experience and the decisions that they made around getting treated for prostate cancer and encouraging Lumbee men to get screened. And so we went out to churches and VFWs and community centers to talk with men about this issue, and have had really great turnouts for those discussions. And we also, in partnership with the Mind Judo Center for Health Equity at Wake Forest, we recently created a report called the Native Pathways to Health report, where we went into the tribal communities and urban Indian organizations to ask tribal members and tribal leaders what are some of the significant health concerns that you are facing. Obviously, much of this information was collected prior to COVID, but we gathered some really good information about their concerns about chronic diseases like cancer, tobacco use, harmful tobacco use, obesity, physical inactivity, poor dietary habits, and things like that. The Mind Judo Center also does some great work in pipeline programming. So they have two ongoing efforts now, one called MedCat, which is Medical Careers and Technology Pipeline, which is a partnership with the Center for Native Health, with Dr. Leffler and the Eastern Band of Cherokee Indians. So they have high school kids from 5 high schools in Western North Carolina. One of those is Cherokee High School. So they come to Wake Forest for a week during the summer and learn about the college experience and health careers. And then an expansion of that effort is AIMS, which is American Indian Biomedical Science Academy, which is a program that's open to the 7 other tribes in the state to again engage those high school kids who are interested in health professions, engage them in the process of learning about health disparities. And also wanted to acknowledge the development of a wonderful partnership between the community outreach and engagement programs at Wake Forest, at UNC, and at Duke. It's an initiative called the Southeastern American Indian Cancer Health Equity Partnership, and we are working towards developing opportunities for education, for training, for research, for our tribal communities across the state. And we have tentatively planned an event in Robeson County for the Lumbee tribe to promote cancer health education and do a number of things that will help engage the community in learning more about cancer risk. And I'm very excited about this and actually this presentation today is the kickoff of our SICEP activities, and we are going to be having other speakers as a part of this initiative in the coming months. So thank you very much. I'm very happy to be a part of this effort today, and wanted to really hopefully bring to your attention some issues that you may have not had an opportunity to think about up to this point. I will point out to you, as I've tried to highlight, that there are a number of issues that we are concerned about and should be concerned about as it relates to trying to get our arms around this issue of understanding the true cancer burden for our Native communities in North Carolina. One of those, as I mentioned, is accurate cancer data that truly represents the cancer incidence and mortality burden for our Native communities. to the extent that we're able to try to get information looking at data specific to certain tribes. I know that does present some challenges because, some of our tribes across the state are very small. So to the extent that we're able to provide information specific to certain tribes, I think that will be very helpful. There's very little cancer screening data, and so I'm hoping that we will be able to gather information through various means to give us a good understanding of what are some of the cancers where screening is not being done well, and what types of initiatives can we put into place to try to address that. Another area I think where we don't know a whole lot is looking at treatment data for patients with cancer, Native people with cancer in our state. So having the opportunity now to collaborate with Duke and UNC might give us that opportunity. And also looking at data for cancer survivorship. So looking to see if 5-year survival rates or quality of life are impacted more adversely for our Native communities, and doing a better understanding of that. And finally, just looking at evidence-based interventions and how we can incorporate those into our tribal communities to try to address some of the issues around cancer screening, care, and survivorship. So thank you again, and I would be more than happy to answer any questions you might have.
And now we can go ahead and open that up for questions. And so anything that you'd like to ask Dr. Bell or Dr. Emerson, please go ahead and share that with us on Poll Everywhere. We'll bring that up as quickly as possible. I see one coming in already. All right. So what can clinicians outside of those communities best help do to help do their part in improving these outcomes?
Well, I would say certainly, making yourself aware of these issues, which is what you're doing today, which is great. But I think also, being a part of advocating for resources that can help address some of these disparity issues. Dr. Emerson may want to add to that.
That's great. Thank you, Dr. Bell.
All right. While we're waiting for additional questions, I'll ask, what sort of impact are you seeing in terms of cancer screening and cancer care, given the current situation with COVID-19 and with the Delta variant? Are you seeing that having a significant impact as it comes to oncology concerns? Either Dr. Bell or Dr. Emerson.
Dr. Bell, you want to answer that?
Yeah, I mean, I'm not familiar with specific data. I mean, just anecdotally, I know that at least in our tribal community, talking with primary care providers, the impact that COVID has had on people seeking primary care has been dramatic, and the number of people who are getting the care that they need is being impacted. And the other thing to keep in mind is that, just like Dr. Emerson mentioned in Navajo, I mean, many of these tribes are in rural areas where there's a long distance to not just primary care, but specialty care. And so that is going to impact the ability that people have in getting care. Now, hopefully, with telehealth and with, extenders, extender providers, I think that will help. But I think we're going to continue to see this issue exacerbated.
Thank you. And we've got one more question. Oh, go ahead, Dr.
Oh, I was just going to chime in real quickly, like, again, returning to thinking about, kind of my home community and coming from that point of that, I guess thinking about representing that community. Yeah, I think, I think we will see those impacts down the road. And like Dr. Bell was saying, we don't have those data available now, but I mean, I know those will be a thing. And those things are already kind of being part of the conversation. And so, one thing that comes to mind for me in my community is it just highlights the inequities that were kind of already there. And so I think the infrastructure is a big one. I think, infrastructurally thinking about access in terms of just basic human right things like access to healthy food, paved roads. Another big one is just telecommunications, and that has just been exacerbated by COVID-19 in terms of online anything, in terms of accessing healthcare, in terms of accessing education. Like that has been a stark disparity in my community in terms of not having that infrastructure there that has been really strong, that has just, been further laid to bear or whatever in terms of looking at that inequality. And so when it comes to some of those projects that I had mentioned, those are all kind of on hold right now. And so I think those will kind of be compounded in terms of down the road seeing those impacts.
All right. Thank you both. Let's take two more questions and then we should probably go ahead and wrap up. The poor access to healthcare really bothers me. Are there any suggestions for what we can do as healthcare providers to push for easier accessibility?
Yeah, so great question. North Carolina, unfortunately, is one of 12 states that does not that has not expanded Medicaid, and so I'd say certainly the people that are most impacted by that lack of Medicaid expansion are some of our poor rural populations, which would include many of our Native communities. So I would say certainly to the extent that you have a voice in the Medicaid expansion discussion, I would say please lend your voice in that space. But I would say also, yeah, I think it's very, very important that our Native youth have an opportunity to learn about pursuing careers in the healthcare environment. And so to the extent that you have the opportunity, if you are a healthcare provider, to provide a venue for American Indian high school students, junior high students to pursue a career in the health professions, that would certainly help a lot.
All right. Thank you so much. Dr. Emerson, anything you'd like to add? All right. Well, speaking of high school, here's this next one. Dr. Bell, what was your scoring average at Pembroke High your senior year? Very proud of you for your work and career involving the Lumbee tribe.
My score, well, it was a very small number. Let's just say that.
All right.
I was known for my defensive prowess, I guess.
There we go. There we go. And thank you for bringing awareness to this and advocating for your communities. And I certainly echo that, as I'm sure most of our audience does. Let's go ahead and wrap up with a couple of things. We want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and UNC Lineberger Comprehensive Cancer Center. I want to thank Mary King, Veneranda Obore, John Powell, Oliver Marth, Jason Paylor for all of their hard work for each and every one of these lectures that we present. There's a lot of work that goes on behind the scenes. So thank you to each of them.